Today we'll talk about easy and straightforward topics. Inflammatory bowel disease, we have an ulcerative colitis and Crohn's disease and indeterminate colitis. Ulcerative colitis is diffuse inflammation involved to the mucosa of the colon and rectum. It's diffuse inflammatory disease involving the mucosa of the colon and rectum. تمام. Crohn's, it's transmural and relapsing, segmental, often granulomatous inflammation that can involve any portion of the GI tract from the esophagus until the anus, usually sparing the rectum. Intermediate colitis, it's around 10 to 15% of all inflammatory bowel disease, and usually there's no clear distinction. Usually involve the colon and rectum. Etiology of inflammatory bowel disease, it's unknown, multifocal with multiple theories. Immunologic could be due to possible defect in regulation of the mucosal immunity with poorly regulated inflammatory response to exogenous antigens, or in genetic, like in Jewish, an association with HLA phenotypes, and can be associated with mycobacterial infection. 20% of patients, they have family history of inflammatory bowel disease, and there are some environmental factors. It's increase in urban dwellers. Pathophysiology, it's due to increased production of mucosal immunoglobulin in response to the initiating antigens, recruitment of inflammatory cells, and then alter the mucosal function and permeability. Age of onset, it's bimodal, 15 to 30 years of age, and from 50 to 70 years of age. It affects females more than male with 1.3 by 1 ratio. Ulcerative colitis, the signs and symptoms including diarrhea, perirectal bleeding, tenesmus, abdominal pain, weight loss, fever, malnutrition, vomiting, and sometimes abdominal masses. The onset is usually insidious or acute and fulminant colitis that requires admission and sometimes requires emergency surgical intervention. It has some extraintestinal manifestations, including joints and skin and eyes and liver and other small bowel related, including spondylitis, sacroiliitis, pyoderma gangrenosum in the skin, erythema nodosum, episcleritis, uveitis, iritis in the liver, primary sclerosing cholangitis, and pericholangitis, and aphthous ulcer, aphthous stomatitis, and in the small bowel, malabsorption, gallstone, and kidney stone. It's important to know that which part of the extraintestinal manifestation can get improved with the treatment control, and some of the manifestation doesn't improve. It's not related to the disease, even if it's severe, or if you control the disease, the manifestation will still there and will not improve, which are ankylosing spondylitis, sacroiliitis, primary sclerosing cholangitis, and pericholangitis. Primary sclerosing cholangitis can be the end complication of ulcerative colitis, which might need later on liver transplant. The disease distribution usually confined to the colon and rectum and nostril regions, and that will differentiate it from Crohn's disease. 30% of patients, they have pancolitis, and 40% left-sided colitis, and around 95% involving the rectum. So when you do colonoscopy and you see the most of the inflammation in the rectum before the biopsy, so you usually have a hint that it is almost ulcerative colitis. And 10% of patients, they have backwash ileitis. Does anyone know what's backwash ileitis? It's from the colon? Yeah, back to the ileum. When patient, they don't have competent ileocecal valve, the inflammation will go back to the terminal ileum. So it's backwash. Usually the bowel will go from small bowel to colon, but this backwash ileitis, the inflammation will go from the colon to the small bowel and result after colon resection. Usually the patient present with anemia, leukocytosis, and high ESR, inflammatory marker, and negative stool culture for ova and parasite, Severe disease may include hypoalbuminemia, dehydration, electrolytes and vitamin depletion, and steatorrhea. Serological markers, it's an ANCA, it's an antibody, and that will differentiate it from the cause disease. Radiological finding on plain abdominal X-ray. It's not diagnostic, but it's important in emergency setting to differentiate if the patient has toxic megacolon or a complication from the toxic megacolon, which might be an perforation. Barium enema, mucosa, which will show mucosal irregularity and pseudopolyps. And on a chronic disease, there will be loss of hastration and chronic shortening and narrowing, and stricture, usually late manifestation, which is usually as a complication of malignancy. Findings هذه واضحة. loss of hastration واضحة للجميع. Endoscopy, it's usually essential for the diagnosis and extent of the disease. There are early and moderate and late findings. Early findings including edema and confluent erythema, then it will progress to granularity and contact bleeding. And late finding, there will be discrete ulcers. Histopathologic finding, mucosal depletion of goblet cells, inflammatory polyps, and crypt abscess. This is the complication of losing the normal histopathologic cells distribution. So this is a picture of an endoscopy. See here the loss of the mucosa and inflammation. This is cellular level finding, you can see. Medical management, minosalicylate and mesalamine, and this is usually the medical management. And there are various formulations allow the different distribution and delivery. Or corticosteroids, usually it's used to control the acute inflammatory activity and does not prevent relapse. When the patient presented to the emergency department and he or she is known to have ulcerative colitis, with an active disease involving abdominal pain and distension and severe diarrhea, usually it is treated with corticosteroids. It is important to subside the inflammation, but it will not prevent the relapse and future complications. So it's just to control the acute emergency situation. No proven maintenance benefits. IV steroids for severe fulminant disease, enema or topical for distal colitis or proctitis. Other forms of medical management, immunosuppressive medications, including azathioprine. It's used for refractory disease. It's not first-line medical management. You start with the previous two medications, and then if the disease is still progressing, you can start with azathioprine. It's rule and allow gradual tapering of the steroids. And it has side effects including hepatotoxicity, pancreatitis, and bone marrow suppression. Usually these side effects general to all immunosuppressive medication. Mechanism of action, it suppresses T cell activity, thus prolonging the therapeutic response. Cyclosporine, another form of immunosuppressive medication, used in severe disease. It blocks IL-2 lymphocyte activation, and usually used in patients who require high dose of steroids, and short term can be controlled up to 50% and eventually need protectomy within a year. So the definitive treatment in severe disease is surgical, not medical. So the medical management is used to control acute settings and to control the inflammatory process of the disease, but the definitive management is surgical, because over years there is risk of cancer. So indications for surgery in ulcerative colitis. There is emergency indications and elective indications. So in urgent setting, as we mentioned before in the finding, the X-ray, which is toxic megacolon, and free colon perforation might happen as a complication of toxic megacolon, or uncontrolled hemorrhage, or fulminant ulcerative colitis. Those are the indication for emergency surgery. Elective surgery, failure of medical management, intolerable side effect of medical therapy, including steroids or immunosuppressive contraindication, and development of dysplasia, evidence of carcinoma, chronic stricture, growth retardation in children. So the elective surgery indication, usually it is evaluated in the clinic, and the decision for surgery will be discussed with the patient in an outpatient setting. It's not an urgent within hours procedure. The emergency surgery, that has to be decided in an urgent time. Surgical options for ulcerative colitis. There are different procedures. You cannot do the emergency procedure in an elective setting. So emergency procedure include lobe ileostomy with multiple colostomies, or subtotal colectomy with ileostomy, or proctocolectomy with end ileostomy. Those are the emergency surgeries. Elective procedure, proctocolectomy with end ileostomy, or subtotal colectomy with ileorectal anastomosis, proctocolectomy with continent ileostomy, which is the pouch, or proctocolectomy with ileal pouch anal anastomosis, or without diverting lobe ileostomy. واضح الفرق؟ طيب المين idea انه during the emergency surgery you try to do less you will not do the definitive surgery during the emergency because the patient has inflammation, he is not in unstable condition, so you will not do anastomosis, you will not do major resection. We just remove the inflammatory or inflammation part and put ileostomy or colostomy. So if the patient had toxic megacolon, you just go inside the abdomen and take lobe of bowel and put it through the skin, ileostomy or colostomy. This type of procedure cannot be elective. Subtotal colectomy with ileostomy, usually we do it in a major hemorrhage. So there is a major hemorrhage from the colon, you go in, you resect the colon and put ileostomy. Proctocolectomy with end ileostomy, the same thing, but if the major inflammation is in the rectum. واضحة الآن؟ The only procedure that you can do it in elective and emergency is proctocolectomy with end ileostomy. You can do it both in emergency and elective. So total colectomy with ileorectal anastomosis, this type of procedure you have to make sure that the rectum is spared and intact, and you have to do surveillance later on to rule out recurrence or involvement of the rectum by ulcerative colitis. Proctocolectomy with continent ileostomy, it's the same, but there is a different type of ileostomy. Proctocolectomy with ileal pouch anal anastomosis, with or without diverting lobe ileostomy. This is the definitive procedure, and most procedure preferred by patient. You know what does it mean, ileal pouch anal anastomosis? Of course, you know proctocolectomy, so it's resection of the rectum and the colon. Total colectomy, if you involve the rectum in the resection, it's called proctocolectomy. Ileal pouch anal anastomosis, usually they take part of the ileum of the small bowel, part of the ileum, and they reconstruct it together to create a pouch. So it will work as a function of the rectum. So they will take it and put it in the pelvis and do anastomosis between the small bowel and the pouch that they created to create artificial rectum. So the patient will have better bowel movements and to avoid ileostomy. And this ileostomy in the last procedure, it is temporary. If we put ileostomy, it's just reverse temporary to protect the anastomosis from leakage. And some surgeons they do ileostomy, and some surgeons they don't do ileostomy. Any question on this slide? This is how you do bowel resection and anastomosis. This is the stapler. The stapler will go in this way, and then you will do a second layer suturing, and then you will create this. You will close this introtomy by hand sewing. switch on. Any question on ulcerative colitis? Right, now we'll move to the Crohn's disease. Signs and symptoms, we know what's the difference, or we know what's the definition of Crohn's disease. Usually the signs and symptoms are the same in all inflammatory bowel disease. It's almost similar. So diarrhea in 90% of patients, usually non-bloody, and ulcerative colitis usually bloody. Recurrent abdominal pain, mild colicky after usually initiated by meals, relieved by defecation, abdominal distension, flatulence, and fever, malaise. These symptoms are shared between all types of inflammatory bowel disease. Clinical manifestations and diagnosis: malnutrition, extraintestinal manifestation in 30% of patients. This is important, and Crohn's disease, usually anorectal lesions can be the first presentation. The patient might present to you with a recurrent anorectal abscesses, fissures, ulcers. This is different from ulcerative colitis. Usually chronic, recurrent, painless or non-healing anal fissures, ulcers, complex anal fistulas, perirectal abscesses, and hypertrophied skin tags. Like this picture. This is from recurrent abscesses and perianal abscesses and anal fissures. Clinical manifestation and diagnosis: disease distribution mainly involve any segment of the GI tract from the esophagus until the anus. Distal ileum most frequently involved. Scalp lesion 12 to 35% of patients. Small bowel only 55%. And distal ileum and colon 35%. Colon only 15%. Rectum is spared, usually. Crohn's disease classified as inflammatory, obstructing, and fistulizing. This is structure. Lab finding: same. Anemia, iron deficiency anemia, and folate and B12 deficiency, and hypoalbuminemia. The difference between the Crohn's and ulcerative: usually Crohn's disease patients, they have B12 and folate deficiency. Why? Because it's involved the terminal ileum and will affect the malabsorption. Serological marker is ASCA. Radiological finding: upper GI serous, narrow terminal ileum and fistulas. By minimum, there will be thickened bowel, longitudinal ulcers, cobblestone formation, and rectal sparing. String sign and terminal ileum. And on the CT scan, you'll see this is thickened wall and narrowed bowel loop or bowel segment. So this is, I think, colonoscopy and retrograde cannulation of the ileum. So the findings in endoscopy is aphthous ulcer, mucosal ulceration, anal fissures, and cobblestone, and segmental agency. The ulcerative colitis usually involve the whole bowel without segmental sparing. So this is the appearance of cobblestoning in endoscopy. This is scalp lesions. And usually the inflammation is transmural, involve the whole wall of the bowel. Intraoperative finding: creeping of the mesenteric fat towards the anti-mesenteric border. I hope there is a picture. Serosal and mesenteric inflammation, bowel wall thickening and strictures, shortening of the bowel and mesentery lymphadenopathy. So the small bowel, usually anatomy. The mesentery will come from the root of mesentery, and some fat will at the anterior mesenteric border. And during the Crohn's disease with inflammation, the fat or the mesenteric fat will go cover the whole bowel as a protective mechanism from the body to help with the inflammation. So when you open a patient during emergency and you see this appearance of the fat, so this will give you a hint that the patient have inflammatory bowel disease, usually Crohn's disease. Transmural inflammation, submucosal edema, fibrosis, non-caseating granuloma. So those are the indications for surgery in a Crohn's disease patient: intractability, intestinal obstruction, intra-abdominal abscesses, fistulas, fulminant colitis, toxic megacolon, This is rare, usually doesn't go with Crohn's disease. Massive bleeding, also more with ulcerative. Cancer with ulcerative, and growth retardation with both. Medical management, more or less the same. Corticosteroids for acute as a patient. This is for mild and moderate disease. Immunosuppressant, azathioprine, 6-mercaptopurine, cyclosporine, usually used when the patient is on corticosteroids, and to avoid side effects of steroids, you start immunosuppressive medication. Methotrexate used in a steroid-dependent active disease and to maintain remission. So it's important that methotrexate used to maintain remission. Metronidazole maybe help to prevent anal complications. Infliximab is anti-tumor necrosis factor alpha, and in steroid-dependent patients, intractable disease, and fistulizing Crohn's. This is supportive management in an acute settings. Usually when the patient presented to the emergency with signs and symptoms of whether obstructing or fistulizing Crohn's disease, you keep the patient in BO on IV fluid and nasogastric tube decompression, and you keep him on TPN to allow healing, and you put the bowel on rest. Once you make sure that there is no fistula and there is no obstruction, you can then choose whether the patient can start on diet or not. Surgical management, there's one point here is important. In Crohn's disease, we only do the surgery for complication. But in ulcerative colitis, some patients, they have ulcerative colitis and controlled over years. They don't have like emergency admissions, and they don't have any emergency complication. But after 10 years, we usually do elective resection. Why? Yes, excellent. Because risk of cancer, and over the 10 years, they do regular colonoscopies to rule out dysplasia, which is a risk of cancer. So Crohn's disease, there is no risk for cancer. Surgical procedure, unfortunately, is not curative. It's only reserved for treating complication. Only resect the grossly diseased, the involved segment of bowel with a small normal appearing margins, distal ileum and cecal resection with ileocolostomy is a common procedure. It is ileocecal resection with ileocolic anastomosis or ileostomy. 60% recurrence and long-term follow-up. Structuroplasty. Anyone knows what's structuroplasty and what's the technique for doing structuroplasty? Usually the bowel segment, when you have a structure in the bowel segment, you do longitudinal incision on the structure side, and you suture it transverse. So this is structuroplasty. It's role in relieving obstruction and chronically scarred bowel without resection, especially useful for multiple symptomatic structures. Why we prefer to do structuroplasty if it's applicable? If it's applicable. Why? If we can't do structuroplasty, we prefer to do it other than resection of the small bowel. Okay, less complication, but then remember, if we said the surgery is not curative, and he will have, if you resect the bowel, he will have the same structure. So we do structuroplasty to preserve the bowel length. If we do resection and then he have complication, we do resection again and again and again, he will have short bowels. So just try to save the bowel as much as we can. Exclusion bypass, higher incidence of recurrence and cancer may be indicated in the following. Bypass unresectable inflammatory mass, gastroduodenal Crohn's disease, and multiple extensive secretions. Anyone know what's bypass? Usually, or sometimes, you have extensive inflammation, causing adhesions between multiple lobes of bowel that you cannot resect. If you resect, it will be 1 meter of bowel because it's inflamed and it's all came together. So what you will do, there is a proximal and distal small bowel, you do bypass. على مخرج جلدي.
مخرج 15.
So we're done with the inflammatory bowel